So, guys, my lecture will be around 20 minutes. In post lecture, I will take you through some of the important key reporting format checklist, which I'll share my screen after the lecture, and we'll have a 5-minute question answer. So it's a total 30-minute lecture. I would request your active participation. If you have any questions, please put in the chat box. Over to you, Sarita, please.
The outset, I would like to thank the organizers for giving me this opportunity to speak on this topic, that's MR checklist in carcinoma of the tongue reporting. MR, as you know, is the main gold standard for diagnosis and management of tongue cancers and becomes an important tool for investigating the carcinoma of the tongue. I've divided my lecture into 4 sections. The first is the ideal imaging technique, then is the anatomy, and then treatment and principles of imaging, and then post-operative imaging. So coming to what is the ideal imaging, we should all remember that tongue is a muscular structure, has a very high, needs a very high contrast definition to be diagnosed. Hence, MR becomes a modality of choice. In less than 10% of the cases where there is bone involvement, a plain CT with bone algorithm reformats serves as a tool to pick up bone involvement, but that only is required in under less than 10% of the cases, and these cases are advanced cases. So remember, planar MR imaging with contrast is the modality of choice for imaging carcinoma of the tongue. So once you've diagnosed the carcinoma of tongue using C contrast and as MRI, CT is used as a problem-solving tool, and for metastatic or nodal mapping, you can either use PET-CT in advanced cases, or you can use non-contrast CT of the thorax. Imaging not only helps in defining the extent of the disease, but also helps in making the choice for the therapy, and we'll see in subsequent slides. So let's look at the anatomy of the tongue. The anatomy of the tongue is important because the treatment is based on the section of the tongue which is involved. There are two parts of the tongue, the oral and the base of the tongue. The oral tongue is the one which is usually managed with surgical management, and the base of the tongue is usually treated with radical chemoradiotherapy. So this forms the anterior two-thirds of the tongue forms the oral tongue. And when the disease is in the anterior two-thirds of the tongue, it is usually treated with radical surgery followed by either chemoradiotherapy or RT alone. If the disease involving the posterior, that is the base of the tongue, which is behind the circumvallate papillae, then the tongue cannot be resected, and these patients are usually treated with radical CTRT. Also, an important point to remember is the base of the tongue disease usually associated with HPV related diseases, and you may have HPV related findings as well in these patients. The division of the oral and the base of the tongue cannot be made because we cannot see circumvallate papillae on imaging. Hence, we use the line drawn from the uvula to the hyoid bone as a landmark to divide base of tongue, oral tongue from base of tongue. On the axial cuts, when you start looking at the tongue, the first thing which you look at is the masticator space. The masticator space is the space which has the masseter muscle and the medial pterygoid muscle and part of the mandible over here. Next to it is the important structure, that is the tonsils over here at the soft palate. And then you have the tongue, which is just starting to appear in the oral cavity. There are some fern-shaped structures over here, that is the intrinsic muscles of the tongue, which inserts into or interdigitates into the lingual septum. Once you go further down, you start looking at inverted V-shaped structure, which is close to the genial tubercle. So this is the genial tubercle. This is the mandible over here. There's an inverted muscle, which is the geniohyoid muscle. Geniohyoid muscle is a very important structure. It takes origin from the genial tubercle, interdigitates and reaches up to the lingual tonsils. There's another V-shaped structure over here. The medial limb forms the hyoglossus muscle, and the lateral limb is formed by the mylohyoid muscle. The mylohyoid muscle forms the floor of the mouth, and posteriorly you have the posterior belly of the digastric muscle. If you go further down, you start getting the structure, that is the floor of the mouth. The floor of the mouth has two compartments, the anterior compartment, which is the submental compartment, and the posterior, that is the submandibular compartment. The submandibular compartment will host the lymph nodes, that are the 1B lymph nodes, and the submental compartment will host the 1A lymph nodes. This is the 1A lymph node over here. Now, why these submental and the submandibular compartment are important? First of all, they form the floor of the mouth, and the disease has gone beyond the surgical floor of the mouth. It's an advanced disease. Reaching up to the hyoid bone will actually make the disease unresectable. Also, the nodes which are present in this area guides you which part of the disease, which part of the tongue is involved. So usually when the anterior tip of the tongue is involved, you have submental nodes. And when you have the sub 1B nodes, that means the lateral edge of the tongue is involved. Sagittal sections are used to look at the hyoid bone involvement, the genial tubercle involvement, and also the involvement of the muscles. So the fan-shaped muscle which you see over here is the genioglossus muscle. It interdigitates and inserts into the intrinsic muscle, forms the bulk of the tongue, and it takes origin from the genial tubercle over here. Then there is floor of the mouth, which is formed by the geniohyoid muscle and the mylohyoid muscle. The superior one is the geniohyoid. It takes origin from the genial tubercle, goes into the hyoid bone, and then next is the mylohyoid muscle. The hyoid bone involvement is an advanced disease, and as per the surgical management guidelines, the patient becomes unresectable if the disease is abutting the hyoid bone. Then the next important cut which you look at is the coronal cut. On the coronal cut, we try to look for is the floor of the mouth, and the floor of the mouth that is formed by the mylohyoid muscle is best seen on the coronal cuts. Any disease abutting the mylohyoid tells you that the floor of the mouth is involved. And then you have the anterior bellies of the digastric muscles underlying the floor of the mouth. Next thing which you try to look at on a coronal is the neurovascular bundle. The neurovascular bundle are actually the flow voids of the lingual artery. You do not see the nerve, but you actually try to look at the neurovascular bundle looking at the flow voids. So any disease abutting the flow voids of the lingual artery will tell you that the neurovascular bundle is indirectly involved. So these are the flow voids within the lingual artery, and the nerve is closely in relationship with the lingual artery. Now, as per the AJCC guideline manual for tongue carcinoma, the T staging of the tongue is based on the depth of invasion, and I'll show you how to measure depth of invasion. So any tumor which has less than 5 millimeter depth of invasion is T1, between 5 to 10 it's T2, more than 10 it's T3, and advanced diseases such as more than 4 centimeter tumor or superficial cortical or deep cortical bone involvement, or the masticator space involvement, or internal carotid artery involvement is T4B. Now, treatment principles and related issues. Let's look at how MR helps into all these management guidelines. MR gives you the depth of invasion and tumor thickness, which guards the prognosis. It tells you whether there is extension across the midline, whether hemi versus total glossectomy is required. It tells you regarding neurovascular bundle involvement, again, which tells you the prognosis and also the type of surgery would be required. If the mandible is required, then the mandiblectomy may be needed, and nodal status is also guiding the neck dissection, which is required in these patients. So I recommend reading our article, which gives a very comprehensive overview of the oral cancers management. And if you look at the key imaging findings, that is a tumor thickness more than 4 millimeter, there is high incidence of neck node metastasis, and elective dissection is required in these cases. DOI, that is more than 10 millimeter, is a poor prognostic marker and consider adjuvant treatment in these cases. If the disease crosses midline, that means the lingual raphe is involved, there's high chances of contralateral nodal disease, hence look for nodal disease on the contralateral side. The contralateral neck dissection and radiation might be required in these cases. Involvement of the bilateral neurovascular bundle, extensive disease, and hence total glossectomy, which is a morbid surgery with flap reconstruction, is needed. Invasion of the extrinsic muscles or the invasion of the floor of the mouth, again, a free flap may be required for these patients. And when there is posterior involvement, these are advanced diseases, primary non-surgical management is used in these cases. Bone involvement, as I said, can guide marginal versus segmental versus hemimandibulectomy. An extension into the masticator space is again a palliative non-surgical candidate. So what is the concept of depth of invasion and how it is different from tumor thickness? Let's imagine 3 kinds of tumor. There's a tumor which is verrucous, not having any exophytic component. There's a tumor which is having exophytic component, and this is an ulcerated endophytic tumor. In a verrucous lesion, the depth of invasion and tumor thickness are equal. In the cases where there's an exophytic component, the exophytic component does not form part of the depth of invasion. Hence, an imaginary line is drawn, and anything which is going beyond the epithelial lining deep into the tissue forms a depth of invasion. Hence, the deeper component is only the depth of invasion. In an ulcerated lesion, the depth of invasion is only the ulcerated component and not the the part which is excavated. So how to look at depth of invasion, this and tumor thickness? You look it at on the contrast enhanced coronal images. Draw a line from the tip of the highest border of the tumor to the inferior border of the tumor, and then take perpendiculars on it. That is the tumor thickness. That's the maximum dimension, mediolateral dimension of the tumor. And if you look at the depth of invasion, it is excluding the exophytic component and only including the endophytic component of the tumor. That forms the depth of invasion. Then you have the various kinds of diseases. Let's look at the different kind of disease and their impact on management. You have a small volume disease. This might be treated with wide local excision. However, this is also a small volume disease, but it is at the origin of the extrinsic muscle, that is the genial tubercle, and would require a glossectomy. Hence, marking the site and the size of the tumor both are very important. Then you have disease which is limited, which may require hemiglossectomy, versus a disease which is reaching or just about to reach midline. Look for the contralateral nodal disease. And these patients might require total glossectomy. And as you look in this case, there's a tumor which is crossing the midline. There's a contralateral nodal disease as well. The neurovascular bundle, we have proposed a classification, and it's now very well used in the clinic. It's a clinically applicable classification. How to define the neurovascular bundle grades? Then you have type 1 neurovascular bundle involvement, where the tumor and the neurovascular bundle has more than 5 millimeter distance between the two. If it is less than 5 millimeter, it becomes type 2. If it abuts the neurovascular bundle, it becomes type 3. And if it is crossing and encasing the neurovascular bundle, then it's become type 4. So this is abutting type 3 neurovascular bundle, and this is a type 4 neurovascular bundle involvement. These are extensive diseases and require total glossectomy. Once you have done total glossectomy post flap reconstruction, imaging looks something like this, with the flap reconstructed over here, and the T1 bright, T2 hyperintense fat is also seen in the MR image. When you have floor of the mouth involvement, you have extensive disease, and that will lead to loss of bulk after surgery, and these patients will also need flap reconstruction. It's important to document the posterior extent of the disease into the hyoid, epiglottis, vallecula, which tells you that it's an advanced disease, and patient might be a palliative candidate. The important differentiation, whether the tumor is arising from the base of the tongue or it is arising from anterior tongue and going into posterior base of tongue, is important. If the disease is exclusively in the base of the tongue, that means it's a base of the tongue disease and should be treated with radical CTRT, and these patients have better outcomes. If the disease is involving the anterior part of the tongue and going into the posterior part of the tongue, then these are advanced cases, and they are usually palliative cases, and they are treated with palliative CTRT. And gross posterior extension, in such patients, the patients are treated with palliative intent, and they are not treated with surgery or radical CTRT. Let's look at mandibular invasion. There may be a disease which is just abutting the genial tubercle. Here, a CT might play an important role to pick early cortical erosion, and which will guide the surgeon about the kind of mandiblectomy he will need. However, this is a gross invasion where you see the signal within the marrow of the mandible, and this is through and through mandibular destruction and fracture, pathological fracture of the mandible. This is advanced cases. Coming to the nodal mapping, there are two kinds of nodal disease. They can be clinically negative node disease or clinically positive node disease. If there is clinically negative node disease, the role of the imaging is to pick occult metastasis. So what you have to do is pick an occult sentinel node metastasis, which will guard the type of the neck resection which will be required. In the clinical positive neck, your aim is to tell the surgeon whether he can resect the nodes safely or not, or whether there is external extension. So any fuzzy margins around the node will tell you there is external nodal extension, and if there is encasement more than 270 degrees, the node becomes unresectable. There are some advanced techniques which have been described in the MR imaging of the tongue. They are more of research interest, and I will not go into the depth of it. But if you're interested, I suggest reading our article again, which will help you what all parameters are available and what are their cutoffs. Coming to the proposed modification by our group, this is already the paper is in the web. You can read this paper again. This is proposed modification of the T staging. So we have proposed that the neurovascular bundle and paralingual distance should be added into the T staging. If the ipsilateral neurovascular bundle is involved, it is a T4A disease, and if the contralateral neurovascular bundle is involved, it's T4B, and we hope that this will be included in the EJCC very soon. This is the recent article which were published, HNCI RATS, where you can download the reporting checklist for the carcinoma of the tongue. This is a comprehensive, extensive reporting format, which, if used in the clinic, can help you spot a carcinoma of tongue. It helps you into various T-staging markers. You have the extrinsic muscle involvement, where the muscle is involved, sublingual space, submandibular space, floor of the mouth, masticator space, posterior extension of the disease, mandibular involvement, nodal staging, presence of extracapsular spread, and the final impression, and any recommendation if to be given. Coming to the post-operative imaging, I request you that you should use a standardized way of reporting the post-operative cases, and I, in my clinic, use NIRADS. The NIRADS category range from NIRADS category 1 to 4, where the 1 represents no recurrence of disease, NIRADS category 2 is low suspicion of index, NIRADS category 3 is high suspicion of index, and NIRADS category 4 is definitive recurrence. So let's look at the case, the algorithm to follow. Usually the follow-up is either with PET CCT or the MR, whichever you've used in the beginning at 6 months. And if 6 months is negative, then you do only CCT or MR of the neck in the follow-up. So what are the recommendations? If NIRADS category 1, a routine follow-up to be done. If it is NIRADS category 2, a short interval follow-up to be done, or a direct inspection to be done. If it's NIRADS category 3, a biopsy is recommended. Even if it's NIRADS category 4, it's definitive recurrence and patient is called for palliative treatment. Let's look at what is NIRADS category 1. NIRADS category 1 is usually there is no abnormal soft tissue, there is no mass-like enhancement. It's just a mucoid density with subtle edema, and or it's a diffuse linear edema enhancement, which is edema. So in this case, if you see, there is a treated case of radically treated case of base of tongue. After 3 months of radical CTRT, there is no enhancing soft tissue, just mild mucosal thickening is seen, and this is a case of NIRADS category 1, a routine follow-up is indicated. In such cases, there is chances to miss disease up to 4%. Another case of NIRADS category 1, where it's a post-operative case of carcinoma of the tongue. There are some surgical staples over here, and there is subtle enhancement, linear enhancement, and this is a post-operative case, and there is no uptake on the FTG. This is a NIRADS category 1 case again. In NIRADS category 2, usually you see some kind of a mild enhancement or a mismatch between enhancement and FTG. This is a base of the tongue case, T4A, which was treated with radical CTRT. There is no mucosal abnormality or abnormal enhancement, but focal FTG uptake. This is a mismatch, and it's NIRADS category 2A, because you can, in 2A, you can look to give a direct examination and rule out if there is any mucosal abnormality. If it is a deep-seated disease, we will call it 2B. So next case is a NIRADS category 3. There is an post-total glossectomy resection area at the anastomotic site. You see that there's a focal enhancing soft tissue with FDG avidity, and the node which has progressed and is now avid. This NIRADS category 3 for the neck and for the primary site. There's a definitive recurrence, and it needs a biopsy to prove the diagnosis. In NIRADS category 4, it's a proven recurrence where you see an obvious mass, it's clinically or pathologically, or progression on radiology, these kind of cases, and these patients are usually managed with palliative intent. So this is a case where there's after total glossectomy and neoesophagus reconstruction, there is a recurrence where the recurrence was actually biopsied, and it's a proven NIRADS category 4 recurrence. So for the NIRADS categories, I again suggest to use a template where it tells you about the primary site, the nodal site, the treatment-related changes, any new malignancies, and final impression. And you have a NIRADS surveillance template also. Again, this can be found from the recent manuscript which we have published. It's called the HNCI RADS. It's on the CRST journal. Both the templates are provided on the journal website. So the take-home message, MR imaging is an important tool for tongue cancer management. It aids in detection, extent of disease, and planning treatment for treatment-naive cases. Introduction of synoptic reporting can be the first step in standardizing reporting lexicon, allowing effective communication between radiologists and the MDT team. And judicial use of FTG has an impact in the management of lung cancer. With that, I thank you for your patient hearing. Any questions, I'll be happy to take.
So I'll share my screen 1 second. Can you see my screen?
Yes,
Sarita?
I can see the screen. Yes, sir.
Yeah, so I've shared with Sarita few of the links for the articles which I suggested if you need to read further about tongue carcinoma. I'll just run you through the reporting checklist in next couple of minutes. So you can use this template which is available from the article online. It makes reporting of the oral tongue very easy. So you start with the laterality, whether it's right sided or left sided tumor. You give the 3 measurements and then depth of invasion, as I discussed in my lecture, how to measure depth of invasion. Then you start the T staging. You look at the tumor, whether it is localized, abutting the midline raphe, or it's crossing midline, whether the extrinsic muscles are involved or not. When you are talking about the extrinsic muscle involvement, look at whether the origin and insertion of the muscle is involved or not, because that also helps the surgeon plan the surgery. The lingual raphe, the lingual neurovascular bundle, which I discussed, NVB, into the 4 grades, you can tell whether it's involved or uninvolved. And if you're not very specific, you can give the grade of involvement. Then it's important to document the floor of the mouth involvement, that is the sublingual and the submandibular space involvement, whether the mylohyoid muscle is involved or not. Then go on to the masticator space, which is the advanced disease. In the masticator space, you can also discuss the involvement of the infratemporal fossa, which is low or high infratemporal fossa. And then you discuss whether the base of the tongue is involved, posterior and caudal extension into the tonsil, and inferiorly into the hyoid vallicula or epiglottis. The mandibular involvement, whether there is breach or not, if any marrow signal intensity is seen, if you're not confident and you want to suggest a problem solving CT imaging, that also you can recommend. And then coming to the nodal staging. In the nodal staging, document the nodes and give your impression whether you are saying the nodes are metastatic, benign, or indeterminate. If it is indeterminate or suspicious, whether you need an additional imaging such as ultrasound to confirm the findings, and also document each level of the node, because it's very important to do a limited neck dissection or a complete neck dissection. Few features which will guide you whether it is metastatic is necrosis. An extranodal spread is very important to be documented in your report, because these patients will require neoadjuvant chemoradiotherapy. Then you have vascular involvement by the nodal disease, whether the nodes can be resected or not, and the largest size of individual node on each side. By giving all this, you can actually give the T and M stage of the patient, and also you can recommend whether the patient would require any further metastatic workup by CECT, NCCT of the thorax or PET CECT. Any questions from the audience? I'll be happy to take. I've shared few links with Sarita. She can drop on the chat box. These are the few other articles. They are free available, and then you can look at the reporting synoptic formats.